she had ALS, which, known as Lou Gehrig's disease, which is an absolutely horrific disease which gradually paralyzes the person, and you lose your ability to move, to speak, to eat, and eventually to breathe. And she took the case. It went all the way to the Supreme Court, requesting permission to choose when she would die.
My guest today on Podcast for Inquiry is Dr. Jackie Nemni. Jackie is a physician specializing in respiratory medicine and spent decades looking after patients in the ICU. She retired from active practice in 2023 and has since been working part-time as a medical assistant in dying assessor and provider. It is the most meaningful and rewarding thing she has ever done, and she wishes she had started sooner. Jackie is also an officiant with Humanist Canada and serves on its board of directors. Today's episode of Podcast for Inquiry is about MAiD in Canada, that is, medical assistance in dying. Jackie and I start by discussing two Supreme Court of Canada rulings 20 years apart and how the latter one opened the door to MAiD. Since medical assistance in dying was legalized in 2016, the criteria have expanded so that more people are eligible. Jackie describes the difference between Track 1 and Track 2 MAiD and the safeguards put in place to prevent coercion and abuse. She also describes several of the arguments employed against MAiD, as well as a current court case that might forbid health institutions from preventing its patients from accessing MAiD services. It is with great pleasure that I bring you my conversation with Dr. Jackie Nemni. Welcome to the Podcast for Inquiry, brought to you by the Centre for Inquiry Canada, a national educational charity supporting your community for reason, compassion, and secular humanist values. You have answers, we have questions. I'm your host, Leslie Rosenblood, board member and secular chair for CFIC. Welcome. Dr. Jackie Nemni, thank you for speaking with me today on Podcast for Inquiry.
My pleasure. Happy to join you.
I want to talk to you today about something you have a considerable expertise in, but is also a fairly controversial topic, even though it's been the law of the land here in Canada for some time. And that is medical assistance in dying, known in Canada as MAiD, previously known as euthanasia, or sometimes even mercy killing. This is something that has happened in Canada, and I'd want you to start our conversation today kind of telling me how MAiD came to be the law of the land in Canada, because because killing somebody else for most of our history has been among the worst laws that you can break, with the strongest of punishments, except in very narrow circumstances, like in acts of war, self-defense, or and so on. But it's very different with MAiD. So what produced this massive change to one of the strongest societal taboos that we've had throughout most of our history?
Yeah, so it did become legal in Canada in 2016, which is really not that long ago in the grand scheme of things, but had been legal in other countries for several years before that. So we weren't the first in the world, but there aren't that many areas. But we could look to the countries where it was legal to get a little bit of guidance or information. So the first person who tried to bring the case to the Supreme Court, you might remember her, it was Sue Rodriguez, which was quite a long time ago in the 90s.
I was much younger then, but I remember that.
We all were. Yes, we were. So she had ALS, which, known as Lou Gehrig's disease, which is an absolutely horrific disease which gradually paralyzes the person, and you lose your ability to move, to speak, to eat, and eventually to breathe. And she took the case. It went all the way to the Supreme Court, requesting permission to choose when she would die, saying, it's my life, it's my body. Why don't I get to decide when it's over? And she lost. So on that occasion, the Supreme Court did not accept that challenge. So
And
the
was she
law,
asking, just to be specific, was she
yep,
asking for uh, assistance in dying, where
yes,
someone would take active steps, or was she asking that she be taken off all and to prevent any kind of medical intervention? Nobody's allowed,
right.
like she was asking that nobody could do anything without which her death
She
would
would,
be her
yes.
death would be certain.
And even though probably to you and to I, those two things sound very similar, in the eyes of the law, they are vastly different. So we have been taking people off of life support since forever, and that's not illegal. Nor would
Okay.
it be illegal for her to say, I don't ever want to be put on a ventilator. So that was always one of her options. So, in other words, she could wait until she was ventilator dependent and die of shortness of breath, which is not really horribly pleasant. And that's what she was trying to avoid. So, no, she
Right.
wasn't asking to have nothing new added. She was asking to actually have her death assisted.
Okay.
And even though the courts did not rule in her favor, she did find a physician. She was in British Columbia. She apparently did find a physician who helped her. Fortunately, nobody knows who that physician was. And I'm glad, because they would have, well, like you said, they probably would have been charged. They would have been charged with murder at that point in time, even though I'm sure they felt they were doing the right thing. So things carried on exactly in the same way. The laws didn't change.
Hmm.
And then there was another challenge which was made in 2015. And in fact, the woman who took that case to the Supreme Court, she suffered from spinal stenosis and some chronic pain, and she would be what we now consider track two. We'll get to that later.
Yeah.
But
Okay.
she,
I definitely have that question coming up.
okay, yes. So she actually brought it to the Supreme Court, and she won that challenge. And by the time it became law, so obviously you get a Supreme Court ruling, and then it goes back to the government, and then there's a delay between when something gets challenged, is made legal or illegal, and when the law is actually changed. So it took until June of 2016 before the law of the land was changed,
Hmm.
and that it was accepted that under certain criteria, that assistance in dying was permitted. Now, that law would not have helped Mrs. Carter, who was the one who made the challenge, because at the criteria that were established at that time, she would not have qualified, but it was the case that made the law change. So in 2016, it became legal to help somebody who had a reasonably foreseeable natural death. So
Hmm.
you might see those initial RFND sometimes in the description of MAiD, the reasonably foreseeable natural death. Nobody gives a definition of what's reasonable. I mean, we all have a foreseeable natural death. I don't know of anyone who could claim immortality. So without any parameters, they didn't say, within the year, within 10 years, within 30 years,
Right.
what's reasonable.
Yes.
But
Reasonable
what
to
it
think that
was
both of us will be perishing from natural causes within the next 50 years.
Exactly. Like it's obviously it's reasonably foreseeable that every human being on the planet is going to die. So
Right.
far, I think, it's still 100% on that front. So the way that got interpreted by different practitioners is variable.
Hmm.
But most people felt, okay, if you were to find out tomorrow that they died, would that be surprising? So that is kind of how you get this person has metastatic cancer. Their death is reasonably foreseeable. It might be tomorrow, it might be in 6 months, it might be in 2 years, but I'm pretty sure that this condition is going to kill them. So the thought is, do you actually currently now have a condition which is likely to kill you? That's how we think of it. And that's how the courts have pretty much interpreted it. In other words, I don't know, if you have glaucoma, okay, well, that's not going to kill you. If you have COPD, it might kill you, but it might not. So if you're an ongoing smoker and your lungs are getting worse and worse and you're on oxygen, okay, you have a reasonably foreseeable death. If you have very mild lung disease, well, maybe not so much. So again, it's a little bit it's a little bit gray in
All
terms
right.
of how it gets interpreted.
I have about 25 questions, and it's just the struggle
Start with
is
one.
what order am I going to ask them in? All right.
Okay.
So the what changed, right, between the first case, Sue Rodriguez, in the
Yes.
1990s, and the case in the early 2010s,
Yes.
that the Supreme Court ruled fairly definitively, and then 20-ish years later, it didn't completely reverse itself. There were lots of qualifications
Right.
and criteria, which you just talked about. But
Yeah.
nonetheless, what was a blanket ban on assisted death before, uh, the door was opened.
I
Whether it
don't
was
know
a
that I
crack
have a
or a
precise.
yawning abyss is open
Right.
to
Yes. Well, it depends
interpretation.
who you talk to. Yeah.
But nonetheless, that's a
It changed.
significant change. So, what was it? The circumstances of the case? Was it a change of law? Was it a change in the zeitgeist and what was deemed acceptable in Canadian society? Something. Was it just a different set of justices over the course of 2 decades? What? Why did they change their ruling from one case to the
So
other?
I don't know that I know the exact answer to that. I don't know that anybody does. But certainly the acceptance in the population at large has grown year upon year. And I think that makes a big difference. Right
Mhm.
now, it stands at over 80% of the population is in favor of MAiD. And so I think when the Supreme Court rules, they have to take into account the desires or the acceptance of the population. And I do think that as a general rule, our societies become more secular. A big part of the prohibition against MAiD was religious. So as society has become more secular, perhaps there's been more acceptance, including in the Supreme Court, which shouldn't have really taken religion into account. But I'm sure, if the population is in general not in favor of something, it's pretty easy for the court to follow along. But when there's a strong societal demand, which there has been, then I think it behooves the Supreme Court to reflect that.
All right. Uh, so we've talked.
Can I just add one more thing?
Sure, of course, yeah.
So one of the things that actually the argument that swayed the Supreme Court,
Yeah.
maybe that's what you're looking for, is, for example, in the Sue Rodriguez case, even though they had ruled against her at the time, the feeling was that she was likely going to choose suicide while she was still able. Right. So she was absolutely adamant that she did not want to live until her body completely gave up on her. And if she wanted to be able to swallow pills, for example, of her own volition, she had to still have mobility, she had to still be able to swallow. And so she would choose to do that at an earlier time than if she could rely on a physician to help her.
Right. So she
So
still
she
objectively had a good quality of life at the time she would have chosen to die.
not according to her, but
Well,
according to
but yeah, I
others,
mean, that's
might have
why I said
thought, yeah, yes, yes.
objectively from the outside.
From the
Of course,
outside, they'd
everyone's
say
quality of
maybe
life is
she would have waited another 2 or 3 years, but she didn't want to miss the window of opportunity to be able
right.
to do it herself. And again, I'm using Sue Rodriguez, even though that wasn't the argument that swayed them, but that was the argument in 2015, was that actually people are ending their lives sooner because they want to still be able to have that control themselves. So we are depriving people of life by not allowing them to choose MAiD. That was how it got worded, to make it that no, we're not actually ending people's lives prematurely. We'd end them prematurely if we didn't allow them to have
Okay.
access.
And So there's a moral objection to killing that I generally agree with.
Yes.
I think that it may be one of the Ten Commandments, and so it
Hmm.
comes down through the Abrahamic faiths, and there's a religious prohibition on murder, but there's also
Yep.
a secular one,
Yes.
uh, and it's one that I agree with. I think it's a good idea that except under the most extreme circumstances, we don't kill each other.
Right. Right.
So why it's very clear that you are in favor of MAiD. You've given us kind of the legal history, and I thank you for that. But let's take a step back and say, why do you and 80% of Canadians, as you said a moment ago, uh, favor MAiD when it really is the deliberate taking of another human life?
Right.
Why are those very narrow exceptions, right, self defense and so on, that were acceptable before, expanded to include a very different category of people?
Right. There are several things that I could elaborate on there. First of all, for the most part, now we're going to talk about what I call the track ones, or the reasonably foreseeable natural death. The people who are dying, they are without a doubt actually actively dying, and most of the people who I see really have a very, very limited time ahead of them. And that time might be filled with pain and loneliness and discomfort and medical intervention and all kinds of horrible things that they don't want. So, by not dying, all that happens is that we prolong their death. We're not really prolonging their life, we're prolonging their death. And I don't
And,
think anybody wants that.
it's
Uh,
basically they're technically alive, but it's all suffering and no
Exactly. They
joy.
don't see any quality of life to these remaining days. So
Okay.
sometimes people will say, yes, I really want to be alive until my daughter gets married or whatever. There's some kind of milestone that they would like to be able to see pass. But otherwise, there's nothing for me left. I've had a full life. I know how it's going to end, and I only see bad things in the future, and I don't want to live that. And who can argue with that? The other thing that you have to remember legally is that suicide is legal, right? If I try to kill myself and I fail, I don't get arrested. I don't go to jail for attempted murder. In our law, suicide is allowed. So I'm allowed to choose for myself to die. So if you help me, are you murdering me? I don't think so, right? It's at my request. So that's, I think, very different than if you show up at my house and shoot me with a gun. That's murder.
Right. So, I mean, as
Um,
with so many things in law and in morality, consent
it's
is
everything.
central.
Absolutely, absolutely. The example that I gave, that I've given in the past to try to help people understand this, is the example of 9/11, right? So those of us who are old enough, probably have a very vivid memory of when the planes hit the Twin Towers,
Hmm.
and there were flames everywhere, and there were people who we saw jumping to their death, right? Which was one of the most horrific
Hmm.
things I think I've ever seen pictures of. I wasn't there, but seen pictures of. And those people, when they showed up at work that day, they had absolutely zero intention of committing suicide. They had no intention of dying. They didn't want to die at all, but they had the choice between either jumping or burning to death. And they chose not to burn to death, they chose to jump. And I think that's what we're doing. These people don't have a choice. They're going to die. Are we going to leave them to burn to death in agony, or do we let them jump? We're not really letting them jump. We're giving them a very calm, peaceful, pleasant death, surrounded by family. So in that sense, they would much rather not be dying for the most part. They'd much rather
Mhm.
not have their cancer, not have these bone pain from the metastases, not have the ALS. So if you could take that away, that would be choice number one. But
Yeah, so
that's not on the
choice one
table.
is so in these cases that you're talking about, what they want is a cure of
What they
whatever
would, what
condition.
if that was possible, that would be their
But
their
because
preference.
medical science has its limits and there are conditions that we can't treat, or
Exactly.
ailments that at a certain point we can only alleviate symptoms but can't address the
Exactly.
causes, then choice two is, don't prolong my suffering and let me
Exactly.
end on my own terms at a time of my choosing.
Exactly. So it's about giving people some options.
Right.
And a lot of people, when I meet with them, they are just so relieved to know that this is an option which is available to them. They won't necessarily use it or exercise that option, but they're just really happy to know. And some of them um, don't pursue it any further. They get that assessment done. And then I never hear from them again. And they either
Okay.
die of their disease, or I don't know if they've changed their mind, withdrawn their request, or whatever. But they really are relieved and happy to know that this is an option that exists,
All
and
right.
that if they get to a point where they've reached their limit, they know that they have an out.
Okay. So you've mentioned a couple of times track one,
Right.
which implies the existence
Of a
of a
track
track
two.
two.
Yes, there sure
So
is.
I would like you to define for me what track one is, what track
Yes.
two is, and if there is a track three and four and seven. So but let's start please with what is track one with regards
Yes.
to MAiD,
So
and then we'll
so
get
when
to the others.
Sure. When the law was first passed in 2016, there was only one track, and that was that you have a disease which has a naturally foreseeable death,
Okay.
reasonably foreseeable death, sorry. And then the law changed again in 2021, again because of a court challenge. So there are some people who are living lives of pain, really, and then it was taken again before the Supreme Court, saying, I don't have a disease that's going to kill me, but I have disease that has entirely robbed me of all quality of life, and why is MAiD not available to me, and saying that that is an injustice. And the Supreme Court agreed, which has muddied the waters tremendously. And I would say that the objections that you see to MAiD tend to be around this track two, usually. And so these are people who do not have a reasonably foreseeable natural death. For example, rheumatoid arthritis. So might be very limited in mobility, might have a lot of pain, but is not going to die of this, or at least very unlikely to die of this disease. So these people received the right as well. And at that point, there started the differentiation between track one and track two. So, track one are the same people who were approved in 2016. So, the people who have a defined illness, which is going to likely kill them. And track two are the people who do not have such an illness. It's more difficult to be approved under track two. It's more difficult to find assessors. And you need to have two people. You always need to have two assessors. That's in track one or in track two. But one of the assessors in track two needs to have some expertise in your condition. So if you don't, so I don't know of any rheumatologists, for example, who practice MAiD. So since we're not rheumatologists, we would need to reach out to make sure that this person had received all of the appropriate and available care to treat their condition before approving them. So it's very um, onerous to actually make sure that these people have met the criteria, and to make sure that they have. It can be difficult even to see these specialists. So if you live in Nunavut, you might really not have easy access to a rheumatology clinic, for example. But before you'll get approved, we need to make sure that somebody with expertise has assessed you and given you all possible treatments to alleviate your pain and your discomfort or whatever is making your life difficult.
Okay, so I want to get into the safeguards and the process in more detail in a moment. So
Okay.
that'll be next. But first,
Okay.
I want to come back to the previous question. You've mentioned track one and track two. Is there or will there be a track three?
I don't know that they will define it that way, but
Well,
there.
I'm just, there's one and two. I'm just, they can name it whatever they want. I'm not hung up on
Right.
track three,
Well,
but it
it
just
might
seems to follow.
it would follow, and perhaps there will be. Right now, you are not allowed to. What you are not eligible for MAiD if your sole underlying condition is a mental illness. That again has been challenged, and well, it came out at the same time as the track two in 2021. The government said, the Supreme Court said that it should be allowed for people who have mental illness, that it is inequality to keep it away from people with mental illness. Now, to try to put in place safeguards, etc., is, as you can imagine, extraordinarily challenging and difficult. And so, but it has not become the law, at least in any province and at this point, but has been postponed multiple times. At this point, we're looking at it coming into effect in 2027 in Ontario. I don't know about the other provinces, but in Ontario, it should become the law in 2027. Um, and that's going to require a lot of help from psychiatrists, from mental health specialists, which, as you know, we have a hard time accessing mental health services at the best of times. So, how
Well,
we're going to have all of this unlimited access to psychiatrists remains to be seen.
yeah, and I mean, I want to get into I want to get into some of the objections again, but in a
Yes,
moment,
sure.
and certainly access to societal supports, including mental health supports, is one of them. But again, uh, I, I I only have 23 questions now, but I still have to ask them one at a time. I do want to get into safeguards and what the
Mhm.
process is, and I'd like you to describe what the process is for track one and track two, and what the protections are against abuse. Because, and I've got basically two broad scenarios in mind. One is people get depressed, right? Like we have people that you know that want to commit suicide and they jump out a window and then like they grab onto the ledge after they've jumped, or they try to commit the suicide, and for whatever reason the attempt fails and they're very grateful that it doesn't. So people change their minds about wanting to die, and
Absolutely.
I don't see why that would be any different in a MAiD scenario than in a more impulsive scenario. And secondly, um, unfortunately, many families, spouses, parents, children, um, relatives, don't have the best interests of someone who's sick in mind.
Yep.
Many do, and that's wonderful, but you cannot count on that. And there's untold numbers of examples of spouses or children who like, just, I want the inheritance, so won't you just die already in
Yep.
one form or another.
Yep.
So MAiD is like, if you
Irreversible.
kill yourself, yeah, it's irreversible. You can't go back. If the person
Yeah.
would have changed their mind, it's too late. If a close relative is able to push the process through on behalf of someone who's ill, again, you can't go back. So please describe the process. Please describe the safeguards, and bear in mind the two, broadly speaking, ways in which it might be abused and be a travesty and not a mercy.
Yes. So what you describe is absolutely the crux of the difficulty and the importance of the safeguards is to make sure that it's not abused and that it is in the person's best interests and not anyone else's. So, first of all, it is something that has to be requested by the person. All right. So, nobody else can make a request to have somebody assessed for MAiD. So, even if you have a power of attorney, they can't make that request. So it has to be made by the person who wants it, and it is rescindable at absolutely any point in time. So they can get their assessments done. And one of the things that I emphasize and that we all emphasize is that you have the right to change your mind. You can change your mind right up until the moment when you actually have the first drug injected. So you are not bound to this decision. One of the things that we try to determine, and one of the questions that is on the MAiD assessment form, is whether there's any evidence of coercion. Now, how do we determine that, and how are we sure of that? I mean, we're human, so we do our best, but can we be 100% certain that somebody isn't in the background saying something? That would be challenging. But if necessary, for example, if you have somebody who you're seeing them with a spouse or with a child and you don't get a good feeling, you can make a request to meet with them on their own. And if you don't get a good feeling from your assessment, you can defer making any kind of decision until you have got all of the information that you need. So the person at this point needs to be at least 18 years old. They need to qualify for healthcare in Canada. And the reason for that is that they don't want people coming from other countries to Canada to have MAiD, since it's not legal everywhere. They need to be competent to make their own decisions about their health care. So that doesn't necessarily mean that they have to be competent on all fronts. So you can be incompetent to do your taxes or to look after your banking, but still be competent to look after your health care. And if you have any hesitation, or if you have any thoughts that perhaps they're not, you can ask for a competency assessment. There are people who are specialized in doing competency assessments, and they will meet with the person and determine yes or no, are they capable of making their own decisions. So that's another one of the safeguards. And you need to make sure that the person who has requested these. So the criteria are, as mentioned, either they need to have a reasonably foreseeable natural death if they're track one or not. They need to have an irremediable grievous condition. Irremediable means that there's nothing that we can do reasonably to help them. So your scenario about the person who's got an episode of major depression, well, that person, we've got a lot of tricks that can help that person. I don't think anybody would say that person has reached the point of there's nothing we can do to help them. And I don't think anybody in Canada would say that somebody in an episode of major depression would qualify for MAiD. So when we're talking about mental illness, it might be somebody who, yes, has had severe depression, but over decades and has failed every treatment up to and including electroshock therapy. That person, well, that might engender a whole other conversation, but not the one who is depressed for a few weeks or a few months or a year, but has not adequately tried, the antidepressants, cognitive therapy, whatever, all of the tools that are at our disposal. And they need to be in a state of irreversible decline. So regardless of whether you're track one or track two, there has to be no chance, and as far as we're able to determine, of you getting better. So you have exhausted what we can do for you. It doesn't mean that if there's some weird experimental treatment that they do only in Geneva, that you need to also go try that. But within what is reasonable, within what is available, they need to have exhausted that to their to what they consider acceptable. So, for example, perhaps many of the people who I've met with who have cancer have had several types of chemotherapy without success. Maybe there's a third or a fourth or a fifth that they could try, but they say, that's enough. This hasn't worked. The side effects are intolerable. You're
Mhm.
telling me that this next round's going to be even worse. No, thank you. So they're not obliged to try absolutely everything, but they need to have pretty much um, given their best shot to what we can reasonably offer. I
All
hope, does
right.
that help answer
No,
your
it
criteria there?
does. It does. So I actually thought of one thing. I know that it was particularly controversial when it was introduced, and it still is.
Yes.
And I want to get into the objections, but before we do, I want to get into. I'd like you to tell me some facts.
Hmm.
Can you tell me how many people are getting MAiD, medical assistance in dying, each year in Canada? Is it having a significant effect on longevity, on on our average lifespan? Who is getting MAiD? Is it mostly men? Is it mostly women, or does it reflect the the 51% or so of the
Right.
population is women? Is that reflected in MAiD? Um, things about you've already mentioned like an urban rural divide
Yes.
when it comes to access to MAiD. Are there other ones along I don't know all of the demographic categories, but along
Yes.
rich versus poor, or along various racial
Right.
or religious groups?
Yes.
Are there great disparities? And can you, like, please tell me who is actually choosing to die and who is actually dying via assisted death, because those two might not be the same.
Right. So those numbers are changing. So it hasn't been around for that long, right?
Right, it's been less
So
than a decade, right? The
it's been
first
less than a decade. So the numbers go up every year, and the percentage of people who die by MAiD has been going up every year, which is what for some people rings alarm bells. But to me, I think that's entirely normal in something that's being introduced, and the criteria have been expanded. So of course the
Mhm.
numbers are going to go up, and it's not anything that you need to panic about. But at the latest census, so some information is being gathered by Statistics Canada in order to get answers to exactly those questions. They can't answer everything specifically, and there's some privacy laws that to limit how much access they get to people's medical records.
Okay, but I'm
But
not asking about like left-handed people who live in this
how many
postal
blue-eyed
code,
people? Yes.
right? Like,
So
but I mean things like
ethnicity and
provincial, rural,
right,
urban,
right,
male, female,
right.
wealth, income,
Yes,
like those
right.
things. I think you can collect those
Yes,
statistics without
yes,
worrying about
yes,
privacy.
yes. They have been collecting. So last year, actually not last year, 2024 is the
Right.
last year where we have the end of the statistical year has been gathered. And in that year, there were just over 16,000, about 16,500 MAiD deaths in Canada, which
Okay.
represents approximately 5% of the population, which is a little bit higher than what they have seen in other countries that have MAiD, like
But
in the
that's
Netherlands or
that's 5% of people who died in 2024,
yes,
not of the population.
correct. 5% of the deaths of
Okay.
2024 were by MAiD. Sorry, yeah, yeah. In 5 years, there'll be nobody left. No, that's not how it's happening. 5% of deaths in Canada. Now, there were just over 22,000 requests made, but actually 16,000 MAiD deaths. So that was 2024. And of those, yeah, they were divided along male female lines, pretty much like the population. They look at income quartiles, and the way they do that is by postal code. So it's not precise uh, to the earnings of the person who requested, but by geographic location is actually pretty good as a
Right.
surrogate for income.
Especially for that level of granularity, right? It's like a
Exactly.
quartile is
And
not
so
particularly specific.
yes. because what some objectors say is that it's preying upon the underprivileged and the poor, and that somehow because those people don't have access to as many services, they're going to be more likely to choose MAiD. And
Well, I
what
was
the
going to bring
numbers
that up later on, but since you did, I'm going to ask:
okay, is
Are
that
they being
true?
preyed upon? Is that true?
So people in the lowest quartile of income die more in general of everything. They die more of heart disease. They die more of everything, cancer. So of those that have MAiD, it follows approximately the quartiles. So they die of MAiD at about the same rate as everybody else dies of MAiD, but they just die more in general. Being poor is bad for your health. That's just the reality. So,
Mm-hmm.
no, they aren't being preyed upon. And certainly, we don't go out and look for them. There's this sense that somehow there are these death squads. We're going out looking for people that are costing society too much money. Well, no, you got to come to us and prove that there's a reason why you need MAiD. It's not ever going to be something that's enforced by an exterior power. The one statistic which has caused a lot of talk and with very little explanation to date is that the vast proportion of people who request and get MAiD are Caucasian, about 95%,
Oh,
which is
wow.
obviously not
Yeah.
representative of the Canadian population, where about 70% are Caucasian. Why that is something that we don't really know. A lot of people have a lot of theories. I view that as another piece of white privilege, that it should be more available to other ethnicities, and it's not that somehow we're disadvantaging Caucasians. It's that there's an advantage, and whether that's because of is it religious, is it societal, is it cultural? I don't know. I don't know the answer, but it certainly does not reflect the general
Mm-hmm.
population. There is a skew, obviously, well, not obviously, but there's more people who are older. The older people die more, and die more of MAiD as well. So again, that goes with the population. So really, and very few Indigenous people. They are gathering those statistics, and there are very few. So really, that outlier is the Caucasians, which I don't know. I don't know why that is.
Okay. Thank you. All right. So we've hinted at a number of reasons why people might object to MAiD, but
Right?
I want to delve into some of the details and just like articulate why people might think it's a bad idea.
Sure.
And I want to start with basically what something I mentioned or hinted at a bit earlier. And like there is a difference. I like there is a difference, and you mentioned it's big in law, but I think there's also a moral difference between um, not intervening to save your life, right, and therefore letting you die,
Yeah.
and taking an active step that causes your death. And like
Yeah.
even outside of the context of MAiD, right? If I, um, if it, I think there is a big moral difference if I see someone floundering in a lake and I don't go in and swim them, or I don't throw a life preserver for them. I mean, that might not be ideal behavior on my part, but that's very different than me putting
Pushing them in.
someone's head under the water and forcing them, right? Like that's and so there is a difference between, to use the example you gave us earlier, taking someone off a ventilator or refraining from providing life saving or life maintaining care, and actively giving someone a lethal injection, or actually, I haven't even asked what the process is,
Yeah.
but there is a big difference in there. So we're kind of crossing a moral line, goes the argument, and that I think is a valid argument. Not necessarily means it's correct and should be determinative,
Yeah.
but they're identifying that argument identifies a genuine difference. So uh, why why should we not just refrain from prolonging someone's suffering by not putting them on a ventilator or by removing a feeding tube or something similar, and take an active step to end someone's life with consent, right? We've
Of
covered that.
course, yeah, yeah. Well, having spent so much time working in ICUs, I would say the difference is not as big as you would think it is. So if somebody is 100% dependent on a ventilator and you take them off the ventilator, I don't really see that that's dramatically different from injecting them with a lethal dose of morphine or something. The end result might be a little bit slower, but it's exactly the same.
Mhm.
It's exactly the same. So it's a little bit of a pretend difference. One is has always been legal, and the other is considered murder. They are, for all intents and purposes, the same. If you have somebody who's dialysis dependent and they say, I've had enough, they're going to die slowly, painfully from their lack of dialysis. You can pretty much guarantee it. And we have made it very clear that one of the tenets of our society is personal autonomy, that you are allowed to you are allowed to say, I don't want dialysis, I'm not going, I can't make you, even if I know that you are going to die without it. You can say, I don't want to be put on a ventilator, which is saying, I would like to die, or I'm choosing to die of this condition, whatever that condition is. That's paramount in our society, is that we don't do things against people's will. So the difference in that case is that if let's say you've just had a massive stroke and you can't speak for yourself anymore, your power of attorney can also make that decision and say, I don't think Leslie would have wanted to be on a ventilator for the rest of his days. And that would be that. Um, so, in a way, it's more permissive when we choose whether or not we're going to add on a life saving thing, method, or withdraw you from. When we withdraw people from a ventilator, it's never with their consent. It's always going to be the power of attorney or something. They can't speak for themselves at that point. So when you look at it from a personal autonomy perspective, I would say this is far more in keeping with our society's core beliefs are, as opposed to somebody else is going to choose whether you live or die. From my perspective, I don't see it as a vastly different uh, distinction.
I think the most common argument I heard when MAiD was being discussed and the law was being drafted, and it was that this is going to become a slippery slope,
Mm-hmm.
and that okay, even if we can't make a strong argument for the reasonably foreseeable natural death, that this is only the start, and the categories are just going to get more and more broad until this is just going to be like a shopping at a cafeteria. I mean, I'm exaggerating
Right.
the argument slightly, but and I'm not certain they were entirely wrong on the basis of this conversation. We've talked about track two, where yes, someone is suffering with a condition that can't be cured. That's now eligible, and in 2 years, or at some point in 2+ years in Ontario, criteria will be broadened considerably to include mental illnesses. And there's nothing to say that in 3 or 5 years beyond that, there won't be another Supreme Court case. There won't be another set of conditions or criteria that are deemed eligible for MAiD. So, uh, is this a slippery slope? And if it is, how do we, or if, rather, if it isn't, how do we stop it from uh, broadening the criteria to such an extent that it just becomes one on a menu of options when you're diagnosed with something that's
Yeah.
unpleasant?
Well, I think there will always be safeguards to make sure that it's not just on a whim. It's not, you know what, you just told me I had cancer. I I can't cope with that. So I hope that we will continue to make sure that there's a rigorous analysis of each situation. I don't think there's an infinite number of people who want to die. I don't think this number is going to continue to grow exponentially. Who are all these people who are going to request MAiD? I think we've kind of gotten to the end of the possibilities. So it's only in people who, for one reason or another, don't feel that they have any quality of life and think that the best option for them is to die. I don't think that doesn't apply to the vast majority of the population, thankfully. And I hope we continue to make sure that that doesn't apply to the vast majority of the population. I think where we will see an expansion and where there has already been an expansion in Quebec is with the possibility of advance directives, which you didn't ask me about. And I was expecting a question about that. So that is something that might be more difficult to manage because it's hard enough when you are already in the situation to make sure that we're doing everything right. It's even harder when you're trying to predict what's going to happen in a situation in the future. That's very, very challenging. And for the most part, I can tell you in my career as a physician and in the ICU, the vast majority of advanced directives that people have are entirely useless. So they tend to say things like, if I'm a vegetable with no hope of recovery, I don't want to be kept alive. And we're like, well, duh, you didn't need to tell us that. We're well aware that those are conditions that in most people, um, they don't feel that that's a really great quality of life. That's not helpful in terms of advanced directives. And the way that it has come to pass in Quebec is that right now you can draft an advance directive stating when you would want MAiD regarding a condition that you already have. You have to have the condition now. So you have to have the Alzheimer's, or you have to have the cancer, or you have to have the renal failure or whatever, but it's not bad enough yet for you to want MAiD. But you're worried that it's going to get to a point where it's bad enough and you're not going to be able to express your desires, either because your dementia has gotten too bad, or you're worried that you're going to lose your ability to speak, or something's going to happen, and you won't be able to express your request. So if you have dementia, let's say, which is the most common reason that people draft these advanced directives, they might come up with a list that says, well, when I can't recognize my children anymore, or when I'm unable to feed and clothe myself, or whatever, when I have to go live in an advanced care facility. So they have various criteria, and they say, when these criteria are met, then I want MAiD. And so they have to draft a complicated document in the company of some kind of a professional to help them, be it their family doctor or somebody else who is well versed in whatever their condition is, and how the future might pan out. And then, you might get to where you hit all those points. You don't recognize your children. You are living in an advanced care facility. You've checked all those boxes, and then the physician or the nurse practitioner goes, but the person is sitting there, very happily singing along to somebody playing the piano, and they don't look like they're in any they're not unhappy at all. They look perfectly happy. And so then the criteria is they also have to exhibit signs of suffering. Now that becomes on the practitioner to determine. They don't look like they're suffering, so we're not going to do it. So it's. I don't know if I've been able to explain how it's extraordinarily difficult to give a good set of criteria that are going to be meaningful to you in the future. I don't know what future me would want or not want. It
Mhm.
depends on an awful lot of things. So I might say, for example, I don't ever want to be dependent on dialysis. That's just awful. And then maybe I'm going to have some kind of condition that knocks out just my kidneys, but everything else is fine. Well, they'll think, well, it's not so bad. 3 times a week, I can go to dialysis. My quality of life isn't bad otherwise. Or it could be the reason my kidneys failed is because I'm riddled with cancer. In that case, I'll say, no, of course, don't put me on dialysis. That's just stupid. I'm dying of 1,000 other things.
Right.
Let that go. So it's not necessarily the dialysis itself that I object to. It's that my quality of life is has
And that's the
disappeared.
straw that breaks the camel's back. On top of everything else,
Exactly.
the dialysis says, that's
It's
it.
one it's one too much. Yeah. It's like, no, I'm not going there. But I don't know. I don't know that today, how I'm going to feel if and when that situation arises. And I would argue that nobody does. It's extraordinarily challenging. So that's where I don't know that it will be a slippery slope. I just think a lot of those advanced directives are going to be useless. That's basically what I think.
All right, a few more questions for you. What about your fellow physicians who don't share your opinion on MAiD?
Yes.
Right? I mean, they could be, because they have religious objections. They're good.
Yep.
They're good doctors, but who are also religious, and their faith makes them think it's a sin or
Yep.
a bad deed, or simply a conscientious objection. They take the do no harm aspect of the Hippocratic Oath seriously and consider MAiD to be
Harm.
harmful.
Yep.
How does if I happen to have a doctor who, for whatever reason, does not agree with MAiD or feels like they would be personally uh, uh, doing a bad thing by
Yes.
by doing so. What am I denied MAiD, or are they forced to go against their conscience and provide MAiD services to me? How does the law, how does Canada navigate that? Because I imagine there's
There
a
are lots of
fair
objectors.
lots of objectors within the medical
Yep.
profession,
Absolutely.
as well as in
Absolutely.
the yeah. Okay, so
Yes.
how is that
So
navigated?
so the Supreme Court actually included a statement saying that you can be a conscientious objector and you are not, nobody is obliged to participate in MAiD. So that is included in the law of the land.
Okay.
So you can rest assured that that has been considered. However, if you as a physician object, it is your responsibility then to refer your patient to somebody else to have them have access to this. That's the truth for abortion as well. And that's a whole other topic, but that's been the law forever. So you can object, you can tell your patient that they're going to hell or whatever, but then you also need to give them, you're supposed to. Does it always happen? I don't believe that's the case. You're supposed to say, for example, where I practice, we have a central coordinating group. That's where the requests for MAiD all are sent. So the physician, whether they object or not, can say, "Look, just direct your request to this place, and they will look after you." That's all they have to do. They don't need to be an assessor. They don't need to even know what the criteria are. They don't need to know whether you would be approved or not. They just need to let you know where to get that information.
Mhm. Okay,
Now,
but they're not allowed to say, "I'm not comfortable with this. I object.
you'll have to do without.
You'll have to do without," um, or or leave it to the patient to find their own way to the assessment center.
That's right.
Doctors are legally obligated to tell a patient who requests information about
Yes.
MAiD, here is
How to
the
get it.
assessment office, and here's how you get in
Yes.
touch with them.
That's
Okay,
the law. Does it happen?
sure. Okay,
I
but
don't know. That is the law.
okay. Um, I remember reading this, I don't know, it was about a year ago, maybe a little bit more, that there was a UN committee that looked at MAiD in Canada and recommended that track two be stopped, that the eligibility for track two, those that are not reasonably foreseeable natural death, um, be stopped. Did you hear about this report?
I no, I'm not familiar with that.
Okay.
Although there have been many arguments about track two, and there was a very damning article in the Atlantic not long ago. I don't know if you read that, which
No.
had the un the very unfortunate and unreasonable title of um, Canada is killing itself. That was the title
Okay.
of the article, which was inflammatory and unreasonable. And what they tend to do in these articles when they and I usually I think the Atlantic is great actually, but they tend to focus on more controversial track two cases. They never discuss the obvious person's dying of cancer. They don't want the pain. They go to the ones and the problem is that one assessor might say yes and one assessor might say no, and that person needs to have two people say yes, but they can continue to get assessments if they want until they get two yeses. So if one person says no, you can continue to request. So in that sense, you can come into cases where, five people said no, but they eventually found two people who said yes. And so that is part of that argument that the track twos in particular tend to be far more messy and muddy and subjective.
Okay. Last question for you. We've talked about patients, we've talked about doctors. What about medical institutions?
Institutions.
That's
Yes,
right. So,
yes, yeah, I knew that this was coming. So yes, unfortunately, well, this is in my perspective, from my perspective, there are institutions that use religious objections as a blanket statement for their entire institution. So any hospital that starts with the word saint generally says there will be no MAiD done here, which means, and some of them, for example, here in Guelph, the chronic care is at St. Joe's, and there are a lot of patients in chronic care who might be eligible or could be considering MAiD. Well, we need to transfer them across the road to the Guelph General Hospital, make a bed available, clean a room just for whatever it is, a couple of hours, so that the person can have MAiD, as opposed to having it in their room where they were all along. So that is something that I find completely ridiculous. And just as of yesterday, there is a challenge up in the court in British Columbia where they are saying that there should not be religious institutional objection to MAiD. The argument being that if you are a Saint whatever hospital, you're not providing religious services, you are providing medical services, which are government funded, taxpayer funded. You should have to follow the rules of the land. You're not allowed to make up your own
right.
criteria of who's allowed to have what. I
But
mean, some of these places won't even offer any kind of reproductive care or trans care. And these things, these are the law of the land. This should not be left to the board of directors or whoever is making these decisions. So if this is a successful challenge in BC, which I hope, who knows, the thought is that then the other provinces would follow rather than have to have their own costly legal challenge, with the thought that whatever the result is in BC would probably be the result across the land. So why go through it? If it fails, I don't doubt that it'll be challenged again, either in BC or somewhere else. But that is the next hurdle. And I think it's a hurdle that should have been overcome a long time ago, that you shouldn't be allowed to have institutions don't have religions. Institutions are bricks and mortar.
right,
They
and
don't
I
they don't have beliefs.
I completely agree. I'm a big fan of both freedom of religion and freedom from
From
religion.
religion.
But this
Absolutely.
is but it applies to individuals. I
Yeah.
don't believe that an institution, right, an organization doesn't have freedom of religion. The
No.
people in the institution, in the organization,
What
absolutely do.
a private or a church, yeah, sure, you are not being funded by the government, okay, but if you are receiving public funds, then you should be subjected to the rules of the public, of the government. You're not allowed to say we want your money but we don't want your rules. That doesn't make any sense to me.
Right. All right. Well, Jackie, this was a tour de force of information on MAiD in Canada today. Thank you so much for speaking with me. Are there any last thoughts that you would like to share with our audience?
Well, certainly, I think one of the things that is super important is that everybody think about the fact that you're going to die. We're all going to die. We don't give enough thought to it. We are a death denying society. So think about it. Think about, how do you want to die? Do you want to die in a hospital? Do you want to die with your family around you? Do you have a power of attorney? Have you given some thought to this? If you're unable to speak for yourself, and this isn't about MAiD, this is just about your care in general, have you appointed somebody to look after you who is going to best represent your wishes, not theirs, yours? So if you have several children, don't necessarily pick the oldest or your favorite. Pick the one who you think is going to speak for you. And if none of your kids are going to do it, ask a friend, ask a neighbor, ask somebody else. But everybody, please think about it. We leave it far too long. We wait until it's too late, or we leave it to our families to make difficult decisions and they don't know what our wishes are. Think about it, write it down, have that conversation so that your loved ones know what you would want.
All right. Dr. Jackie Nemni, thank you so much for educating me on this very important topic on Podcast
Thank
for
you.
Inquiry today.
Thank you, Leslie.
If you enjoyed today's podcast, please consider giving us a 5-star review and showing your support at patreon.com/podcastforinquiry. Email us podcast@centerforinquiry.ca. We'd love to hear your perspective. The Podcast for Inquiry is brought to you by the Centre for Inquiry Canada. We are a national educational charity supporting reason, compassion, and secular values. Help us support rational discourse and evidence-based decision-making by becoming a member at centerforinquiry.ca/join. CFIC is on the web, on Facebook, and you can follow us on Blue Sky at CFI Canada. Podcast for Inquiry is produced and edited by Zach Dumont and Martin Zielinski. Music by Anthony Lazzaro. I'm your host, Leslie Rosenblatt. See you next time.